So probably some of you will have heard the phrase TDM, not tedium, that's something different, but therapeutic drug monitoring. And it's a blood test that is done, or should be done anyway, when people start taking azoles. So itraconazole and voriconazole, definitely. And it's just to check that it's at the right level in your blood. So for voriconazole specifically, if you've got not enough, the tiny little bear with some flowers, it's just not effective. So less than 1 milligram per litre is one common cutoff. There's just not enough there. It can't clear away it can't target the fungus well enough. There's a sweet spot, which, you know, a reasonable width of band. So between 1 and about 5 and 5.5 mg per litre, that's called the therapeutic levels, which means it's the right amount to work. And that's something that they calculate from lots of different clinical trials, loads of experimental data in test tubes, and horrible mathematical modelling that I do not pretend to understand. But lots of data, a lot of data goes into finding exactly these what these levels should be. And if you have too much in your blood, so over 6, then you start getting really high risk of having toxicity. So not just unpleasant side effects, but really at those high levels, it can start really quite damaging your organs and become a real problem, a serious problem. Don't take these numbers too literally, because it always depends on the patient. So some infections need higher levels. So some, like a very severe infection or something in the brain, you would normally give a higher dose. So if you think that's that, any of the numbers in this, if they don't quite match your numbers, listen to your doctor rather than this, because this is just a general illustration. So you need this, just shows you need just the right amount. So what controls how much of the tablets get into your blood? Everybody's different. So once the voriconazole, when you swallow it and it gets absorbed into your bloodstream and circulates all around the body, it goes through the liver. And so the liver is the main site of where medications are and metabolites are processed. So the liver, it has a lot of enzymes, and these can they can modify or break down medications. So they call it metabolizing them. So you're putting drug into your system with the tablets, and then the liver gradually over the course of the day breaks it down, and then you take more. So it's like a balance between how much is going in and how much is being broken down. So the enzyme that does that, well, the main one anyway, the only one I'm going to talk about today, it's called CYP2C19. And that actually, it's not just voriconazole that it's working on. It controls the levels of about 1 in 10 drugs. So not just voriconazole, but also common things like clopidogrel, omeprazole for stomach acid, Valium, all kinds of different things. So it's very versatile. And the gene that encodes it, there's different versions of it, so different variants. So you might so number 2, it's called a slow metabolizer gene. So you're metabolizing it slower, so the amount in your blood can rise higher. Variant number 1, scientists call it wild type, which is a strange way of just saying just normal, what you would expect, what most people have. And if you have variant number 17, you go the other way. It breaks it down much quicker, and so the level in your blood tends to be lower. So this is just a graph showing how different it can be. So where there's all these little spikes, all the little serrated bits, what that means is when it goes high, that's when they've taken the tablet, and then it gradually comes back down again, and then they take the next tablet, and then the next. So just over the course of days and weeks. So don't worry too much about this graph. It's just to show that you can have quite a bit, if depending on what genes for CYP2C19 you've got, depending on which ones you've got, it can be quite a big, it can make quite a big difference. So you can give two people the exact same dose, and one of them, it's as if they've got 4 or 5 times more than the other person, and that is a big difference. That really is a big difference. So it would be really good if we could account for that in treatment. Just a note, it's not only genetics that controls this difference. So if somebody's liver is damaged in some way, like with cirrhosis, or if they've had problems with alcohol that's damaged it, that will also affect voriconazole metabolism. So that's why a doctor giving you azoles might ask about something like drinking. It's that's the reason. They're not being nosy. It's to make sure your organs can handle it properly. So who could if we test these genes, who could it maybe help? Probably not CPA or ABPA, because those are much longer, slower form of the disease. Then you go to an outpatient clinic that you don't really get diagnosed in hospital. You would come to a clinic like NAC a couple of times a year. So when you start on azoles, the pharmacist has a lot more time to build the dose up and run the blood test to make sure that everything's on track. That works pretty well for CPA and ABPA patients. But on the other hand, if you have someone with invasive aspergillosis, so that's quite often somebody who's already in intensive care maybe with COVID or flu, maybe they've got maybe they've got something like they're a transplant recipient, or they've got some big immune problems. That's much more urgent. It's just every hour counts in an infection like that. So what tends to happen is you give them more voriconazole to begin with. So they call it a loading dose. You give them a big load of it first to get everything moving. But obviously, if somebody's a slow metabolizer, that creates a risk there. But the problem is, if somebody already has invasive aspergillosis and would benefit from this test, it's a bit too late to start ordering genetic testing, because for something like this, it could take a couple of weeks to come back, by which point you're just too late. So one thing that's been suggested is for people that are known to be at risk, so hematology patients, so that's like people with leukemia or lymphoma. They know when they're going to be getting their chemotherapy, so they know when they're going to be really at risk from aspergillus. So it's been suggested if they know in advance what their genetic type is, that could help them if they get ill. So it's still fairly early days on this. It's not something that's already sort of widely done. It's being tested at the moment to see whether it helps. So there's I found one paper. It doesn't have the results yet. The study's still ongoing. It was just a description of how the study will be run. So in their introduction, the group they're looking at in very high risk patients, they reckon about 1 in 15 of them will get invasive aspergillosis at some point, which it must be really frightening to be in that situation. And of the people who do catch it, about 1 in 3 of those won't make it. So they are horrible numbers, really. So the study, it's called Vorigen, and quite a decent sized group. There's 146 people, and they're going to compare people who get their voriconazole dosing just chosen in the normal way versus being guided by the genetics. And so they're measuring a few different things. So like, do their levels get into the correct range quite quickly within 5 days, and how much side effects do people have in the sort of 3 months, how many of them fail treatment in 3 months, and also does it save money, which isn't the main thing you're thinking of when you're a patient, but when you're trying to persuade hospitals to do things like this, it can be very handy to say, this will save you X number of dollars. It's quite a good convincing tool. We are going to be doing a pilot study on this at NAC. We haven't started yet. It's still just in the getting all the pieces together stage.